Start panninga, sir.
Yes, ma'am.
Okay. Hello, everyone. Very good evening to all. So welcome to this test and discussion session in physiology. So hope all of you have given the test. So we have an analysis of the test also. So we're going to discuss the 100 questions that you had given in your test and discussion. So before that, so I just want to ask, how was the questions? Those who had attended the exam, how did you find the questions? Easy, moderate, or difficult? Yes, you can post it you can type in the chat box. Yes, how did you find the paper? Okay, I think it was a moderate to difficult type of paper. Okay. See this paper, so I have made it in such a way that it had questions from all the previous year exams, especially your 2021, 2022 exams. The areas which were more focused in the last 2-3 exams and also the last 2 NEET-CET exams. So that was the portion that was mostly concentrated in this test. So if you had really done this test well, it means that you are good with your topics. So almost all of them were like high yield topics only. So to start with the first question, so what we'll do, so I'll just show you at least initially how far you are in the competition, and you can just look how your competitors have done the test, how many of them have given the answer right and how many of them given the answer wrong, so that you can judge at which position you are in. So the first question, so this was a comparatively easier question, clinical based question on diabetes mellitus. An 18-year-old girl with type 1 diabetes mellitus presents with symptomatic hyperglycemia. The patient is started on insulin. The metabolic effects of insulin include which of the following? So the question is on the actions of insulin, what insulin does to glucose levels. That's about the question. So let's see how many of you have answered this correct. Yes, most of you, the first question, most of you are right. Decreased lipolysis. Yes, that was the answer. C, decreased lipolysis was the answer. Most of you have done it good. So it means you know about diabetes mellitus and insulin you have learned already. So I'll just go through the actions of insulin and we'll come back to this question again. The actions of insulin. Insulin is basically an anabolic hormone. So what do you mean by anabolic hormone? Insulin will increase the storage forms of carbohydrate, proteins, and fats. That's why it's called anabolic, building up hormone. It's not breaking down hormone. Whereas thyroid gland and the thyroid hormones, they are catabolic hormones. They will break down most of the substances. So they are catabolic, but insulin is anabolic. It would increase the storage form of all your carbohydrates, proteins, and fats. So let's discuss the actions of insulin. When actions of insulin, what insulin does to carbohydrates, proteins, and fats. In carbohydrate metabolism, the insulin, this is the blood glucose. Insulin pushes all the glucose from blood into the cells and increases the storage form of carbohydrate. What is the storage form of carbohydrate? Glycogen. It increases glycogen synthesis. This is what insulin does to blood glucose. So now you realize how insulin is able to bring down the blood glucose levels by sending blood glucose into the cells for glycogen synthesis. It is dissipating the levels of glucose from the blood. That is how insulin is able to bring down your blood glucose levels. So this is the effect of insulin on carbohydrates. On proteins, almost the same effect. Blood levels of amino acid. So when you have lots of amino acids in the blood, insulin pushes the amino acids into the cells for protein synthesis. For protein synthesis. See, insulin is increasing the storage form of proteins. Proteins are synthesized. Fats. What insulin does to fats? Insulin increases free fatty acid synthesis. So insulin is increasing all the storage forms of carbohydrate, proteins, and fats. This is how insulin is able to bring down the blood glucose levels. What is the relation between insulin and GLUT4? See, GLUT is a glucose transporter. It's a facilitated type of diffusion. There are many types of GLUT. Insulin-dependent glucose transporter is called GLUT4. So what is the mechanism of this GLUT4? See what insulin does to heart cells, cardiac muscles, skeletal muscles, and adipose tissue. See what insulin does. It sends the blood glucose from the blood is pushed into the cardiac muscles, skeletal muscles, and adipose tissue. The transporter which does this, that is called glucose transporter, GLUT type 4. In cardiac muscle, skeletal muscle, and adipose tissue, it is GLUT4. That is why GLUT4 is called as insulin-dependent glucose transporter. Because only if insulin is there, it can push the glucose through GLUT4 into these cells. By pushing blood glucose into heart cells, skeletal muscles, and adipose tissue, insulin helps to bring down the blood glucose level. Yes, that is the ultimate thing of insulin, no? To bring down your blood glucose level. So this is with the help of GLUT4. And GLUT4 is called insulin-dependent glucose transporter. It's a facilitated type of diffusion. So this is the mechanism of action of insulin. So back to the question. Look at the question. The metabolic effects of insulin includes which of the following? Increased proteolysis. Is insulin breaking down proteins or synthesizing proteins? It is synthesizing proteins. This is wrong. Increased ketogenesis. So what is ketogenesis? Ketogenesis means when fats are taken into the cells to increase free fatty acid synthesis. This is the role of insulin. But what is ketogenesis? Breaking down of free fatty acids to release ketone bodies. This is called ketogenesis. See, insulin is exactly doing the opposite. Ketogenesis is breaking down of free fatty acid into ketone bodies. But what is insulin doing? It is increasing free fatty acid synthesis. So exactly it's opposite. Insulin is not ketogenic. It is not increasing ketone bodies. So this is also wrong. Decreased lipolysis and increased lipolysis. So what is insulin doing to fats? Is it breaking down the fats? Breaking down of fats is lipolysis. Is it increasing lipolysis? No. It is decreasing lipolysis. It is helping in building up of free fatty acid synthesis. It is not breaking down free fatty acids. Lipolysis means breaking down of fats. That is not happening. So the metabolic effect of insulin includes decreased lipolysis. C, decreased lipolysis is the answer. So only when you know all about the actions of insulin, you'll be able to answer these questions. So that is about insulin and the first question. The second question, area highlighted C in the diagram given below denotes. So this is a tough question. So in this question, the diagram that is shown here is called the Davenport diagram. The name of this diagram, Davenport diagram of acid-base balance. So only when you know all about acid-base balance, you'll be able to answer this question. So we will discuss acid-base balance and we'll then come back to this question. So acid-base balance, the answer is metabolic acidosis. First of all, you should know some basics about acid-base balance. Yeah, only then you'll be able to answer this question. So whenever you have a clinical question on acid-base balance, how will you approach that question? The first step, usually more questions are asked from acid-base balance. I think in the last two exams, around 5 to 6 questions only from acid-base balance related to physiology, biochemistry, and medicine. So understanding acid-base balance is very important. Definitely you have questions from these three subjects based on acid-base balance. So I'll give you a stepwise approach. How will you answer acid-base balance questions? So first step, look at the question. Any acid-base balance disorder, the question will have this following data. You will have pH, bicarbonate, and carbon dioxide. These three data will be there in the question. pH, bicarbonate, and carbon dioxide. You should know how to correlate these three. First step, look at the pH value. What is the normal plasma pH range? 7.35 to 7.45. That is a normal pH of the plasma. Any pH less than 7.35, that is called acidosis. So if in the question the pH is less than 7.35, then it's called acidosis. You will name that disease as acidosis. So now your diagnosis is fixed. You have found out acidosis. So now you have to find out what was the cause of acidosis in that patient. There are two causes of acidosis. The first cause of acidosis, acid is more. Directly it will cause acidosis. Yes. We are talking about the volatile acid here. Which is the volatile acid? Carbon dioxide. Bicarbonate is the base. Carbon dioxide is the volatile acid. When you have increased levels of carbon dioxide is a volatile acid. If acid is more, can you have acidosis? Yes. When partial pressure of carbon dioxide increases, that can cause acidosis. So if we find out that carbon dioxide is the cause of acidosis, so then we can make sure that the organ that is giving you trouble here is lung. Only when you have something wrong in the lungs, you can have increase in carbon dioxide level. So the organ that is giving you problem here is lung. If you find out that lung is giving you the trouble, any acid-base disorder related to lung, it will be named as respiratory disorder. So in this question, carbon dioxide level is high. If carbon dioxide level is high and this has caused the acidosis, you will name it as respiratory acidosis. There are two organs which are involved in acid-base balance, lung and the kidneys. When there's something wrong with the lung, you will name that disorder as respiratory disorder. It could be respiratory acidosis or respiratory alkalosis, but it's called respiratory disorder. If anything is wrong with the kidneys, then it is called metabolic disorder, metabolic acidosis or metabolic alkalosis. And both of them will compensate for each other. If there's anything wrong with the lungs, kidneys will compensate. That is called renal compensation. And if there's anything wrong with the kidneys, lungs will compensate. That is called respiratory compensation. So over time, you'll see that any type of acid-base disorder, over time, it will be compensated. If lung is giving the trouble, you will have renal compensation. If kidney is giving the trouble, you will have respiratory compensation. So this is a respiratory disorder. Lung is giving the trouble. So who will compensate for this? Kidneys. So that is called renal compensation. How will the kidneys compensate? Already your blood is in acidosis. So much of acid is there. How will the kidneys compensate for this? What is the role of kidneys in acid-base balance? So kidney does something to this bicarbonate. Almost 90 to 99% of this bicarbonate is reabsorbed by the renal tubules. The kidney reabsorbs the bicarbonate and gives it to the blood. That is the role of kidneys in acid-base balance. So in renal compensation, in order to balance for this acidosis, see what the kidney does. It will start to reabsorb more and more of bicarbonate. when it is reabsorbing more and more of bicarbonate. Why is it reabsorbing more bicarbonate? To add this bicarbonate into the blood, that is going to neutralize your acidosis. So in order to neutralize the acidosis, it is reabsorbing more and more of base bicarbonate and adding it into the blood. So as a result of compensation, your bicarbonate levels will slowly start to increase. There's an increase in bicarbonate level. So that is the renal compensation done. So increase in PCO2 is the cause of this problem, and increase in bicarbonate is the compensation done by this. Compensation done. See, any question you should be able to find out which is causing this problem and which is the compensation done. So here, increase in carbon dioxide is the cause, and increase in bicarbonate is the compensation. That's why it's called respiratory acidosis with renal compensation. Clinically, when can you have this type of a problem? A respiratory acidosis with renal compensation. Decreased ventilation. You're not breathing properly. So if you're not breathing properly, your ventilation is very slow, decreased ventilation. The use of ventilation is to take oxygen to send out carbon dioxide. If your ventilation is very decreased ventilation, then you will stop sending out CO2. So a patient who hyperventilates will send more CO2 out. A patient who is hypoventilating, decreased ventilation, will slowly start to accumulate carbon dioxide inside. See, now you understand what is the cause of this increased carbon dioxide levels, decreased ventilation. Whenever you breathe slowly or ventilation is very less, decreased ventilation, it means you're accumulating carbon dioxide inside. So decreased ventilation is a cause for respiratory acidosis. So this is the first one. The second cause of acidosis. The second cause of acidosis could be a fall in the level of bicarbonate. So what is bicarbonate? Bicarbonate is a base. If base level is falling, bicarbonate base is decreasing, automatically blood will go for acidosis. If base is decreasing, it will go for acidosis. So this can also cause acidosis. A fall in bicarbonate level. This can also cause acidosis. So if there is something mistake with the bicarbonate level and that is causing acidosis, now which organ is giving the trouble? Lung or the kidneys? The kidneys. If you have anything wrong with carbon dioxide, it means there's something wrong with the lung. So you call it respiratory. If you have any change in bicarbonate, then the problem is with the kidney. If there's something wrong with the kidney, you will name that disorder as metabolic. So this becomes metabolic acidosis. Metabolic acidosis, something wrong with the kidneys. Who will compensate? Lungs will compensate. How the lungs will compensate? Respiratory compensation. As a result of compensation, see what the lung is doing. Already blood is in acidosis. Too much of acid is there. So this lung will start to hyperventilate. It is trying to push out some carbon dioxide because carbon dioxide is a volatile acid. Already you have so much of acidosis. So this lung is trying to push out carbon dioxide out. When it is trying to push out the CO2, it is trying to bring down the acidosis. So as a result of respiratory compensation, it is pushing out carbon dioxide out of the body. When carbon dioxide is pushed out, carbon dioxide level goes down. That's why, as a result of compensation, PCO2 levels have gone down. So this is the compensation done. So you should be able to identify which is the cause and which is the compensation. So in this one, decrease in bicarbonate is the cause, and decrease in carbon dioxide is the compensation. That's why it's called metabolic acidosis with respiratory compensation. When can you have this type of metabolic acidosis? See, one thing is there's something wrong with the kidney. So it could be a renal failure or renal injury, renal tubular acidosis. Or as a result of metabolism itself, too many metabolic acids are produced. What are the metabolic acids? Lactic acid, ketoacetic acid, sulfuric acid, phosphoric acid, or all these are metabolic acids. If normally itself they are more produced, that's called metabolic acidosis. Metabolic acids are more produced, that's called metabolic acidosis. Example, lactic acidosis, ketoacidosis. Ketoacidosis can happen in diabetes mellitus and starvation. So all these can cause metabolic acidosis. Either something wrong with the kidney or metabolism itself is more. So more metabolic acids are produced, therefore metabolic acidosis. So you should understand the difference between volatile acid and metabolic acids. Volatile acid is carbon dioxide. Lungs will take care of the carbon dioxide, volatile acid. But metabolic acids are produced as a result of metabolism. Carbohydrate metabolism will produce lactic acid. Fat metabolism will produce ketoacetic acid. Sulfur containing proteins, when they are metabolized, sulfuric acid. So all these are produced as a result of metabolism. Volatile acid, lung will take care. These metabolic acids, your kidneys will take care. So this is about the second one, metabolic acidosis with respiratory compensation. So that is acidosis. Alkalosis. Looking at the question, if the pH value is more than 7.45, then it's called alkalosis. So if you look at the pH, if it's more than 7.45, it means alkalosis. Your diagnosis is fixed alkalosis. What are the causes for alkalosis? The first cause for alkalosis, direct cause. Alkalosis means alkaline substance is more. What is that alkaline substance? The base. What is that base? Bicarbonate. If bicarbonate is more, bicarbonate is more. Bicarbonate is a base. If base is more, directly it will cause alkalosis. So when bicarbonate is more and it has caused alkalosis, which organ is in trouble now? Kidneys. So how will you name the disorder? Metabolic alkalosis. When kidney is in trouble, who will compensate? Lungs. Respiratory compensation. How will the lungs compensate? Body is in alkalosis, so lung will try to accumulate carbon dioxide inside the blood. Body is in alkalosis. If you accumulate carbon dioxide, which is an acid, this acid will neutralize the alkalosis. So the lung will breathe slowly and it will accumulate CO2 inside. That CO2 is an acid which can neutralize the alkalosis. So that is called metabolic alkalosis with respiratory compensation. So overcompensation, you'll see that PCO2 levels have also gone up. So increase in bicarbonate, this is the cause of this alkalosis, but increase in PCO2, this is the compensation done. So in the same patient, bicarbonate will be more, carbon dioxide will be more, but increase in bicarbonate is the cause. Increase in CO2 is the compensation. Clinically, when can you see this? Vomiting of gastric contents. Gastric content contains hydrochloric acid. Hydrochloric acid contains H plus and chloride. If you lose too much of H plus, hydrochloric acid, if H plus acid is lost, then it will go for alkalosis. That's called metabolic alkalosis. Vomiting of gastric contents. The other cause for alkalosis, fall in carbon dioxide. Carbon dioxide is a volatile acid. If acid level is going down, it can cause alkalosis. Yes. Fall in carbon dioxide. This can cause alkalosis. If that is the cause, carbon dioxide is the cause, which organ is giving the trouble? Lungs. So you call it as respiratory alkalosis. Who will compensate now? Kidneys. Renal compensation. How will the kidneys compensate? Blood is in alkalosis. So it will try to stop the reabsorption of bicarbonate. Bicarbonate is a base. Already there is so much of alkalosis in the blood. So kidneys will stop reabsorbing bicarbonate. Over time, as a result of compensation, you will see that bicarbonate levels are going down. So that is the compensation done. Bicarbonate levels have gone down. So that's why it's called respiratory alkalosis with renal compensation. Yes. Who will have this type of problem? Increased ventilation. People who hyperventilate. So hyperventilating is fast breathing. When you do fast breathing, it's called hyperventilation. When you hyperventilate, you will keep sending CO2 outside. When carbon dioxide moves out, carbon dioxide levels will go down. So patients who hyperventilate, increased ventilation, they can have respiratory alkalosis with renal compensation. This is how you should have a stepwise approach to acid-base disorders. So we'll come back to this question. So in the diagram, they're asking to assess this acid-base diagram. So I'll show you the normal diagram. This is the original diagram given in Genome. Davenport diagram of acid-base balance. We're just going to correlate all that we had learned now. We'll put it into this diagram. On x-axis, pH value. On y-axis, bicarbonate. And you have carbon dioxide levels. So the boxed one are all carbon dioxide. 80, 60, 40, 30, 20, and 10. These are all the CO2 levels. You have pH, bicarbonate, and carbon dioxide. We're just going to put all this together in this diagram. So first, pH less than 7.35. So this part of the curve where pH is less than 7.35, the left side of the curve. Acidosis. If pH is less than 7.35, acidosis. Any pH more than 7.45, the right side of the curve, alkalosis. First, you classify acidosis and alkalosis. So this part of the curve, left side, acidosis. On the right side, you have alkalosis. Look at acidosis. Two types of acidosis. Respiratory acidosis and metabolic acidosis. So how will you further find out this? Respiratory acidosis, the blue portion of the curve. Respiratory acidosis means carbon dioxide has gone up and that has caused acidosis. That's called respiratory acidosis. Lung is the cause, carbon dioxide is the cause. See, that is why you match that blue portion with the CO2 levels. See, it corresponds to 80 and 60. What is the normal CO2 levels? What is the normal partial pressure of carbon dioxide? PCO2. Arterial blood, 40. Venous blood, 46. So 40 to 46 millimeters of mercury. That is the normal value of PCO2. But look in this respiratory acidosis, 80 and 60. So carbon dioxide is more, that has caused acidosis. So you call it as respiratory acidosis. So the blue portion denotes respiratory acidosis. The green one, metabolic acidosis. When will you call it as metabolic acidosis? Something wrong with the kidneys, something wrong with the bicarbonate that has caused acidosis. Any fall in bicarbonate levels. When bicarbonate level falls, bicarbonate is a base. When base level goes down, it can cause acidosis. That is called metabolic acidosis. So you just match this green portion of the curve with bicarbonate levels. See, it corresponds to 10 and 5. What is the normal bicarbonate level? Normal bicarbonate levels, 25 milliequivalents per liter is the normal bicarbonate. But in this case, see, only 10 and 5. It's called metabolic acidosis. So the left side of the curve denotes acidosis. So just by looking at carbon dioxide and bicarbonate levels, you should be able to correlate whether it is respiratory acidosis or metabolic acidosis. Increase in carbon dioxide, respiratory acidosis. Decrease in bicarbonate, metabolic acidosis. Now, alkalosis, the right side of the curve, alkalosis. Metabolic alkalosis, the yellow portion. Metabolic alkalosis means metabolism or the kidneys bicarbonate. Increased level of bicarbonate. When you have increased levels of bicarbonate, directly it can cause alkalosis. Normal value is 25 milliequivalents. Look at that yellow portion of the curve. It corresponds to bicarbonate values of 40 and 45. See, bicarbonate is gone up. So that yellow portion denotes metabolic alkalosis. The last one, respiratory alkalosis. The respiratory alkalosis is fall in the level of carbon dioxide. Carbon dioxide is an acid. If acid level falls, it can cause alkalosis. That is called respiratory alkalosis. Fall in the partial pressure of carbon dioxide. Look at the red portion of the curve, corresponds to carbon dioxide values of 10 and 20. Carbon dioxide values of 10 and 20 less. Normal values 40 to 46. So CO2 has gone down. That has caused alkalosis. This is called respiratory alkalosis. So this is the Davenport diagram. See, whenever you have this question on this diagram, you should be able to correlate the pH first, then find out respiratory or metabolic, and accordingly you can place with bicarbonate and CO2 levels. Now look into this question. The area highlighted C. So what is C? Green portion of the curve. So look, what is C? This one, metabolic acidosis. The answer is metabolic acidosis. Yes, we have a query there. And please explain again compensation in respiratory alkalosis. Dr. Mohit, compensation in respiratory alkalosis. So this one you're asking? Yes, please look at this. Compensation in respiratory alkalosis. The cause for respiratory alkalosis is fall in carbon dioxide level. Carbon dioxide is an acid. If acid levels are falling, it can result in alkalosis. So that is called respiratory alkalosis with renal compensation. So how will the kidneys compensate for this? See, when body is in alkalosis, what the kidneys will do, it will stop reabsorbing bicarbonate. If the kidney is reabsorbing bicarbonate, it will add the bicarbonate into the blood and it will further aggravate alkalosis. So to compensate for alkalosis, kidneys will stop reabsorbing bicarbonate. So bicarbonate reabsorption comes down. So overcompensation, bicarbonate level will come down. So that's why bicarbonate level has fallen. So this is the compensation done. So that's why it's called renal compensation. Compensation done by the kidneys. How has the kidneys compensated? It has stopped reabsorbing bicarbonate. Thereby, alkalosis is coming down. So that is the compensation. Yes. Dr. Mohit, was that clear? Is Varsha. Metabolic acidosis with renal respiratory compensation. Okay, metabolic acidosis. See, metabolic acidosis. See, you don't complicate too much. You just look at the word and try to find out. Metabolic means something wrong with the kidneys or the metabolism. So it's related to bicarbonate. So metabolic acidosis, bicarbonate is low, that is the cause. Anything wrong with the kidneys, lungs will compensate. So respiratory compensation. How will the lungs compensate? Already body is in acidosis. So what the lungs can do, it can remove the carbon dioxide. Already it's in acidosis, so it's trying to remove the volatile acid CO2. So the lung will hyperventilate and it will push out the CO2. When it sends out the CO2, carbon dioxide is an acid. If acid is moving out of the body, acidosis will come down. So as a result for this compensation for this acidosis, respiratory compensation, PCO2 levels are falling because the lung is hyperventilating to push the acid out. So fall in PCO2. So that is the compensation done. Yes? Clear, Dr. Varsha? See, when you look at this all together, it will look confusing. But if you have one question on acid-base balance, you concentrate on that one question, you will be able to get the answer. Okay? Yes. So now I think you should be able to correlate this diagram. So if possible, You just try to fill in the spaces. You just write down what is A, what is C, what is B, and what is D. Okay, without looking into it, just try to write down. Yes, C is metabolic acidosis. The answer for this question is option D, metabolic acidosis. Is the third question. We have another question coming up on acid-base balance. So again, we'll come back to this. Match the following causes of edema, the corresponding change in Starling's forces. Yes, before that, let's see how many of you have done this acid-base balance right. Yes, most of you have done it right. Metabolic acidosis. So most of you have got that right. Third question. Match the following causes of edema with the corresponding change in Starling's forces. That also most of you are right. The answer is option C. We'll go back to the question. This question is on change in Starling's force and edema. We'll analyze edema and we'll come back to this. So what is edema? So edema means excessive accumulation of fluid. Excessive accumulation of fluid in which compartment? Inside the cell or outside the cells? Outside the cells. When you have excessive accumulation of fluid outside the cell in the interstitial space, that is called edema. So this is the interstitial space. The yellow colored space is the interstitial space. If you have excessive fluid accumulation in that yellow colored space, the interstitium, that is called edema. First, let's understand about the normal direction of flow from the capillaries. You can see the arterial end, venous end, and the capillary bed. From the capillaries, there's fluid shift into the interstitium. From the interstitium, it drains into the lymphatics. The green ones are all lymphatics. This is the lymphatic. The normal direction of the circulation is from capillary bed into the interstitium, from interstitium into the lymphatics. It goes like this. Anywhere you have obstruction in this flow, you will have excessive accumulation of fluid in the interstitium. So this space, there is excessive accumulation of fluid. So this is called edema. What are the causes of edema? There's so much of fluid accumulated outside the cells. What are the causes of edema? There are 4 important causes of edema. Almost all the clinical and surgical conditions will fit into this. The first cause of edema, increased capillary hydrostatic pressure. See, when you have increased capillary hydrostatic pressure, the capillary hydrostatic pressure, the role of capillary hydrostatic pressure is to push the fluid from capillaries into the interstitium. That is what the capillary hydrostatic pressure will do. It will push the fluid from capillary into the interstitium. So if you have increased capillary hydrostatic pressure, it's going to push more fluid into the interstitium. Therefore, you will have excessive accumulation of fluid here and therefore edema. So increased capillary hydrostatic pressure can cause edema. Yes. What are the cases, clinical conditions where you can have increased capillary hydrostatic pressure? On one side, capillaries are connected to the arteries. On the other side, capillaries are connected to the veins. So whenever there is an increase in arterial pressure or increase in venous pressure, increase in arterial pressure or increase in venous pressure, that can increase the capillary pressure. So look at the causes. Increased arterial pressure. When can you have more pressure in the arteries? Hypertension. Or increased venous pressure. When can you have more pressure in the veins? Right ventricular failure. Gravity. When you stand for a long time, venous pressure increases. That's why you have edema when you hang your legs for a long time, in a long distance travel. Slowly they'll swell up. venous thrombosis, a clot, a thrombus in the veins that can block, that can raise the pressures. So increased in arterial pressure as in hypertension, or increased venous pressure as in right ventricular failure, gravity, and venous thrombosis. So all these are causes of edema. That's the first cause of edema. The second cause of edema, decreased capillary oncotic pressure. What is oncotic pressure? Oncotic pressure is the pressure contributed by plasma proteins, albumin, globulin, and fibrinogen. They are the plasma proteins which contribute to oncotic pressure. So what kind of a pressure is oncotic pressure? The oncotic pressures are, they are going to pull the filtration from the interstitium into the capillaries. So the oncotic pressures, they will take the filtration, they'll pull the filtration from opposite direction, from the interstitium into the capillary. Hydrostatic pressure in the capillary will push the fluid from the capillary into the interstitium. But oncotic pressure exactly opposite. If you have oncotic pressures in the capillaries, so that will pull the fluid from the interstitium into the capillaries, because plasma proteins, they can pull fluids, they can absorb the fluid. So this is the role of oncotic pressure, pulling the fluid from interstitium into the capillary. If you have decreased oncotic pressure, it means this pulling force is decreased. So when there is decreased oncotic pressure, fluid is not pulled from interstitium into the capillary. So fluid accumulates in the interstitium itself, thereby resulting in edema. Decreased capillary oncotic pressure can also result in edema. What are the causes? Yes, Dr. Karthik, right, reduced oncotic pressure is good. What are the causes? Oncotic pressure means related to proteins. What are the plasma proteins? Albumin, globulin, and fibrinogen. Hypoalbuminemia, as in protein energy malnutrition and liver failure. Protein energy malnutrition is you don't eat enough proteins. Or liver failure, because liver only produces plasma proteins. So liver failure, you can have hypoalbuminemia. These are the causes of decreased capillary oncotic pressure. The other cause, lymphatic obstruction by Ucheriria bancrofti. That's the organism in filariasis, and that has a tendency to block the lymphatics. So if lymphatics are blocked, a block in the lymphatics, this organism blocks the lymphatics. So from the interstitium, fluid cannot drain into the lymphatics because it is blocked. So if this direction is affected, again you'll have accumulation of fluid in the interstitium. So any lymphatic obstruction, as it can happen with filariasis, Ucheriria bancrofti, it will go and block the lymphatics. So that is called lymphatic obstruction in filariasis. That's called the elephantiasis, or the elephant leg. The last cause, increased capillary permeability. See, when capillaries are broken, they will leak the fluid into the interstitium. So increased capillary permeability, as in burns or trauma. There's some injury to the capillaries. So the capillaries are leaking the fluid into the interstitium. Burns and trauma. That's why whenever you have any injury, immediately you'll have swelling. Because the capillaries are broken, they are leaking fluid into the interstitium. So any injury, you should have swelling. That is the fourth cause of edema. So these are all the clinical integrates of edema, both in medicine and also in surgery. So now back to that question. Which of the following causes of edema with the corresponding change in the Starling's force? Yes, so you should match this. So we'll match that. Hypertension. So what is happening in hypertension? Increased arterial pressure. So what is the cause of edema and hypertension? Increased hydrostatic pressure. This one. Protein energy malnutrition. Protein energy malnutrition. Proteins are not there. Proteins are responsible for oncotic pressure. So this should be related to oncotic pressure. Filariasis, Bancrofti, blocks the lymphatics, lymphatic obstruction. Burns. So what happens in burns and trauma? Capillaries are damaged. Capillary permeability increases. This is related to capillary permeability. So if you match like this, you will get C. C is the answer. We have just matched the cause of edema with the Starling's force. C is the answer. The fourth question. We'll see how many of you have done this good. Fourth question. Identify the true statements regarding action potential in the given image. The question is about action potential. Yes, most of you have given it right. Action potential curve. I think the question that was given is, yes, this one. This was the curve that was given. So what is this curve? Action potential of cardiac ventricle. The cardiac ventricle action potential. There are different types of action potential based on whether it is the nerve action potential or muscle, in muscle, whether it is skeletal muscle, cardiac muscle, or smooth muscle. So this is typically the cardiac ventricle action potential. We'll learn about cardiac ventricle action potential and we'll come back to this. The cardiac muscle action potential. We have three action potential diagrams here. Nerve action potential, cardiac ventricle action potential, and SA node action potential. I think all of you would have learned about action potential. So I'll just go through that. In action potential curve, the upstroke is called depolarization. The downstroke is called repolarization. So let's take the nerve action potential, depolarization and repolarization. What ions are responsible for depolarization and repolarization? Depolarization is due to sodium entry, that is called sodium influx. Repolarization is due to potassium efflux. Yes, good, Dr. Karthik, good. Depolarization is sodium influx. Repolarization is potassium efflux. So this is the major event in action potential, that is nerve action potential. Now we'll see what is the difference between nerve action potential and cardiac action potential. First, we'll do the cardiac ventricle. Cardiac ventricle means your myocyte, the normal cardiac fibers. SA node is the pacemaker. So that is different. First, we'll do cardiac ventricle. We'll just see what is the difference between nerve action potential and cardiac ventricle action potential. In cardiac ventricle action potential, you have the upstroke, depolarization, which is due to sodium influx. Same. You have repolarization, which is due to potassium efflux moving out. That is also same. But in between, you have this plateau phase or flat phase, phase 2. Why is this phase a flat phase? So what happens in cardiac fibers, in cardiac cells? Repolarization, the repolarization has started in phase 1 itself, and there's full repolarization in 3. In between, when the cell is going through this phase 2, repolarization is because of potassium efflux. In between, in cardiac ventricles, you have opening up of calcium channels, L type of calcium channels. See, L means long-lasting calcium channels. Long-lasting calcium channels. So what these channels will do, they would send in calcium ions. Potassium is a positive ion moving out. Calcium is a positive ion moving in. Both the positive ions will balance each other. Therefore, there is no change in the potential. That's why during that phase 2, because of opening of these L type of calcium channels, calcium moving in, potassium moving out, both are balancing each other, no electrical activity. See, this is what corresponds to the flat ST segment. See, in ECG, when you learn about the cardiac ECG, you will see that in between PQRST waves, you'll have one flat segment, the ST segment. So that is flat segment because that ST segment in ECG corresponds to this plateau phase in the cardiac ventricle. See, ECG is basically sum of action potentials. So ECG is corresponding with the action potential curve. So in ECG, flat ST is flat. But in action potential, that corresponds to this plateau segment of this cardiac ventricle. So when the heart is going through this plateau phase, when you record ECG, it will give you ST segment. That's why ST is a flat. In ST, there's no wave there. ST means it's a flat segment. So this is cardiac ventricle. So one difference between nerve and cardiac ventricle is the plateau phase. Plateau phase is very specific for cardiac fibers. SA node action potential. SA node action potential is very special because that's the pacemaker. It produces the rhythm for heart rate. That's the pacemaker, and the potential is called pacemaker potential. Look at the action potential of the SA node. You have depolarization. Elsewhere, you will see depolarization is due to sodium entry, but only here depolarization is due to calcium entry, L type of calcium channels and calcium coming inside. That itself is the difference. Elsewhere, sodium entry causes depolarization, but only here calcium entry causes depolarization. Repolarization, same. Potassium efflux. But in the beginning of this depolarization, there's a slopy phase, phase 4. And this phase 4 is called as pacemaker potential. Pacemaker potential or slow diastolic depolarization phase. Pacemaker potential or slow diastolic depolarization. See, this only is responsible for the pacemaker activity of the SA node. What is that pacemaker activity? Every part of the heart can produce an electrical impulse, not only the SA node. Every part has pacemaker activity. But SA node becomes the dominant because of this pacemaker potential. So what is that pacemaker potential? This slopy phase is called pacemaker potential, phase 4. So otherwise you will see that it will be flat and then you'll have action potential. But here, see there's a slope and after that you have action potential. So this slope is called pacemaker potential. What is the use of this slope? Why do you have this slope? This is something you have to think very logically. So let's say this is your developing action potential. Let's say this is the ground floor. You have to climb up to the 5th floor. To climb from ground floor to 5th floor, see how much effort you have to put, or there is already a step there which has elevated already to the 4th floor. Now, from 4th floor, you're trying to go to the 5th floor. Now it becomes very easy. From ground floor to go to the 5th floor, that's like from RMP going to the action potential. But in SA node, already there is that slope there, phase 4, which has shifted the RMP to a more positive value. So already it has gone like this. So from top of this point, this is like 4th floor. From 4th floor to go to the 5th floor, it's very easy now. So every action potential will have this slope. So the slope is elevating the action potential. It's making it more easier. So that is why in SA node, action potentials are occurring at very high rate, very quickly, because they have this slope which is already pushing it to a more positive value. So on top of that, getting an action potential becomes very easy. And that is why SA node is called as pacemaker and this slope is called as pacemaker potentials. What are the channels that contribute to this phase 4, the pacemaker potential? IF. IF means it's a funny channel which will allow in non-specific cations. Some non-specific positive ions come inside. T-cal means transient T type of calcium channels. NCX, sodium calcium exchanger, NCX. So funny current IF, transient calcium channels, T-cal and sodium calcium exchanger. So these three only contribute to this pacemaker potential. The slope is because of these three channels. So that is the SA node potential. So the salient features of SA node, one thing is that depolarization not due to sodium entry, calcium. The other thing is it has that slope, pacemaker potential. So what is the clinical importance of learning all this? So you have to apply it on the pharmacology and medicine. There are drugs called anti-arrhythmic drugs. Anti-arrhythmic drugs. These drugs, they block one of the phases of the action potential curve of the heart. This way they are used to control arrhythmias. So what are the anti-arrhythmic drugs? There are different classes of anti-arrhythmics. Class 1 anti-arrhythmic, they block the first phase. Depolarization itself is blocked. Voltage gated sodium channel blockers. See, the phase 0 is depolarization due to sodium influx. So voltage gated sodium channel blockers, by blocking this depolarization, they are bringing down this arrhythmia. That is class 1. Class 1A, procainamide quinidone. Class 1B, lidocaine mexiletine. And class 1C, flecainamide propofenone. These are all class 1 voltage gated sodium channel blockers. Class 3, on the other side, they are blockers of repolarization. Repolarization is due to potassium. So they are all potassium channel blockers. Amiodarone, ibutylide, lufetilide, sotalol, they are all potassium channel blockers. In between depolarization and repolarization, you have plateau phase, phase 2, that is blocked by calcium channels. So that is called class 4 antiarrhythmics. Calcium channel blockers, verapamil and diltiazem. Because plateau phase is due to L type of calcium channel. So calcium channel blockers will block the plateau phase. So class 2 is missing here. Class 1, class 3 and class 4, they act on cardiac ventricle action potential. Class 2, this acts on the pacemaker potential. Class 2, beta blockers, they decrease the slope of this phase 4. They act on pacemaker potentials. Propranolol, metoprolol. Propranolol and metoprolol. So this is the mechanism of action of these antiarrhythmics. Back to the question. Identify the true statement regarding the cardiac ventricle action potential. Phase 0, due to opening of voltage gated sodium channels. What is phase 0? Depolarization, that is because of sodium channels. Yes, this is true. Phase 4 is called slow diastolic depolarization. See, slow diastolic depolarization is seen in SA node action potential, not in cardiac ventricle. This is a cardiac ventricle action potential. Plateau phase blocked by tetrodotoxin. What is tetrodotoxin? Tetrodotoxin is a toxin that is present in puffer fish. It's a sodium channel blocker, voltage gated sodium channel blocker. That is tetrodotoxin. Plateau phase is due to calcium channels. So sodium channel blocker tetrodotoxin cannot block the plateau phase because plateau phase is because of calcium. Calcium channel blockers only will block phase 2. This is wrong. Tetrodotoxin is a sodium channel blocker. RMP minus 55. What is the RMP of cardiac ventricle? The RMP of cardiac ventricle minus 90 millivolt. This is the cardiac ventricle. Yes, good, Dr. Karthik. Cardiac ventricle minus 90 millivolt. SA node minus 55 millivolts. So this is actually for SA node, not for cardiac ventricle. So true statement is only A. True statement is A. Yes, so many of you have answered here. Yes, good. The fifth question, identify the correct sequence of events following stimulation of lower motor neuron that innervates the skeletal muscle. So this is about the neuromuscular junction and the events in the neuromuscular junction. So let's see how many of you have answered this right. Most of you have gone for the wrong answer. Answer is D. Might be it's a sequence of events, so it might have been difficult for you to arrange in sequence. See, these sequential type of questions are more important in any set. It's an any set pattern question. Sequential arrangement. It's time consuming when you have questions like this. So we'll do that. Answer is D. So what is the neuromuscular junction and what are the events happening in the neuromuscular junction? Neuromuscular junction, it's the junction between the neuron and the muscle, the lower motor neuron and the muscle. What are the events taking place in the neuromuscular junction? So we'll draw the neuromuscular junction. Let's say this is a neuron. This is a muscle. Junction between this neuron and the muscle, that is called neuromuscular junction. This yellow space is the neuromuscular junction. What is the sequence of events happening in the neuromuscular junction? When an action potential is stimulated in the neuron. See, in lower motor neurons, which innervate the muscle, the corticospinal tract comes from the brain and it stimulates these lower motor neurons in the spinal cord, and they will in turn go and reach the muscle. This is the sequence. When corticospinal tract comes down and stimulates these lower motor neurons, what are the lower motor neurons? A alpha and A gamma, which goes to the muscle, they're called lower motor neurons. When lower motor neurons are stimulated, the first event that happens here is, opening of voltage gated sodium channels. Sodium channels open, there is sodium entry in a neuron. First event is sodium should come inside. When sodium enters inside, whenever sodium comes inside, this would depolarize. So this results in depolarization, and an action potential is set up. So this action potential travels along the neuron like this and reaches the axon terminal. In axon terminal, you have calcium channels. They are voltage gated calcium channels, and calcium enters. So in the axon terminal, the role of calcium is it can push these vesicles containing acetylcholine. They will push the vesicles containing acetylcholine into the neuromuscular junction and release acetylcholine into the neuromuscular junction. Yes, good, Dr. Karthik, release of acetylcholine. So after that, the fourth event, release of acetylcholine. This acetylcholine crosses the neuromuscular junction. This is the neuromuscular junction. It crosses the neuromuscular junction to reach the muscle. And on the muscle, you have receptors for acetylcholine. They're called acetylcholine nicotinic receptors. Nicotinic receptors. Once acetylcholine binds to the nicotinic receptors, then you have opening of sodium channels. Again, you have action potential in the muscle. See, all that is in the neuron. Now it's in the muscle. Same thing happens. Sodium, action potential. And then you have calcium. But muscle already has stores of calcium. That is called SR, sarcoplasmic reticulum. Stores of calcium. So SR releases calcium. And this calcium, when released from SR, sarcoplasmic reticulum, releases calcium, and this calcium helps to move actin over myosin. When actin is moved over myosin, muscle contracts. So this is the sequence that takes place in the neuromuscular junction. Starting from the lower motor neuron, sodium channels, action potential, calcium channel opening, acetylcholine released, binds to nicotinic receptors. Again, sodium, action potential, calcium, but here calcium is already there in the muscle, SR, sarcoplasmic reticulum, storage of calcium. Actin is moved over myosin. So this is the sequence. So back to the question. Answer is option D. So let's trace that. So first thing that happens, opening of voltage gated sodium channels in the lower motor neuron. Yes. Then followed by development of action potential in the lower motor neuron. Yes. And followed by E. Opening of calcium channel in the axon terminal. Yes. Followed by F. Development of action potential in the muscle fiber. Yes. Followed by release of calcium from SR, followed by this. Actually, this is this one, D, B, E, C, A, F, G. So this is the one. This is the answer. So first is opening of voltage gated sodium channels. Then you have B, development of action potential. Then E, opening of calcium channels, release of acetylcholine, then acetylcholine binds to nicotinic receptor, then F, development of action potential in the muscle fiber, and then it is G, release of calcium from SR. The answer is option D. So when you have these type of questions, sequential questions. So in any set, you have sequential questions, extended match and all that. Just to give you an exposure to the highest edge of questions, we had included these sequential questions. So please don't do mistake in sequential questions. See, any set exams, what they focus on is they are making you to know everything about that topic. Just like that, if you learn a topic and you go for any set exams, very difficult to answer those questions. Only if you know everything about that topic, you will be able to do any set exam. That is what they are focusing on, the institutes. You should have learned everything related to the topic. So the sixth question is an acid-base disorder. So we'll see how many of you have done this right. Acid-base disorder. A 43-year-old male patient presents with the following lab values. Yes, most of you have done it right. Good. The answer is C. Most of you are right. Respiratory acidosis with compensatory metabolic alkalosis. So how will you approach this question? Stepwise. pH 7.2. If pH is less than 7.35, then it's a case of acidosis. So this is acidosis. Look at carbon dioxide and bicarbonate values. Normal value of carbon dioxide is 40 to 46. Bicarbonate is 25. So carbon dioxide has gone up, bicarbonate has gone up. Increase in carbon dioxide is the cause of this acidosis, because increase in carbon dioxide can directly cause acidosis. So you name it as respiratory acidosis. An increase in bicarbonate is the compensation done by the kidneys. So compensatory metabolic alkalosis. Then we should find out of the carbon dioxide and bicarbonate, which is the cause and which is the compensation. So here, increase in carbon dioxide, yes, directly it can cause acidosis. So that only is the cause. Increase in bicarbonate is not the cause, because if bicarbonate increases, it will not cause acidosis. It would have caused alkalosis only. But your diagnosis is acidosis. So of these two, increase in carbon dioxide matches more with acidosis. So this is respiratory acidosis. Who will compensate? Kidneys will compensate. Metabolic alkalosis. How the kidneys will compensate? Already the body is in acidosis. So the kidneys will start to reabsorb more and more of bicarbonate. They will add it into the blood. So this bicarbonate will neutralize the acid, neutralize the acidosis. So overcompensation, bicarbonate level increases. So the answer is C. Respiratory acidosis with compensatory metabolic alkalosis. So the seventh question. A 54-year-old asthma patient presents to the medicine OPD for evaluation. Which of the following is expected to be increased in this patient? The answer is option D, only A and B. So this is the answer. The question is about asthma patient. Asthma is an obstructive disease. So we have to learn all about the obstructive diseases and restrictive disease. Only then we can come to this question. Which of the following is increased? Total lung capacity increased, residual volume increased. That is the answer. So we learn about that and we'll come back to this. Obstructive disease and restrictive diseases. One investigation for differentiating obstructive disease and restrictive disease is Tiffany index. What is Tiffany index? Normal Tiffany index is FeV1 by FVC. FVC is forced vital capacity. FeV1 is when you do a forced vital capacity, how much air comes out in the first second alone. That is called FeV1. So FVC is forced vital capacity. FeV1 is forced expiratory volume in the first second. Normally, when you do this, look at the graph, time on x-axis and volume in liters on y-axis. Just match the FVC value. This is FVC. Normal value 4 liters. So FVC 4 liter, 4.0. Out of this 4 liter, how much air comes out in the first second? So just mark first second on x-axis with y-axis around 3.3. So FeV1 is 3.3. FVC is 4 liters. FeV1 is 3.3. When you take a ratio, FeV1 by FVC, 3.3 by 4. That will give you 83%. This is called the Tiffany index, FeV1 by FVC. So a normal Tiffany index is 83%. So what does this tell us? If you are normal, if you have no lung disease, out of the 4 liter, 83%, that is 3.3 liter, 83% you should be pushed out in the first second itself. 83% of the air should come out in the first second. If you have no disease, 83% of the air should come out in the first second itself. That's why the normal index is 83%. So now, obstructive disease and restrictive disease. How will you differentiate? In obstructive disease, FVC is 2.0. In restrictive disease also, FVC is 2.0. See, this tells us that you have obstructive disease or restrictive disease. Anyway, there's a lung disorder. So the forced vital capacity is no more 4 liters. Forced vital capacity has decreased from 4 liter to 2 liter. So in both the conditions, FVC has decreased from 4 liter to 2 liters. So what is obstructive disease and restrictive disease? Obstructive disease is when you have any obstruction, you will have more difficulty in breathing out the air. You will have more difficulty in expiration. So obstructive diseases, more difficulty with expiration. What are the obstructive diseases? COPD, chronic obstructive pulmonary disease. What are the COPDs? Emphysema, chronic bronchitis. Emphysema, chronic bronchitis. The other obstructive diseases, asthma, bronchiectasis, even cystic fibrosis. In cystic fibrosis, you can have a thick mucus which will obstruct. So in all these diseases, there is some obstruction to the expiratory flow. So expiration is more affected in obstructive diseases. Restrictive diseases. When you have a restriction in the lung, it is not expanding. So when you try to take in air during inspiration, there's a restriction that it's not expanding. So in restrictive diseases, you will have more difficulty with taking in air, more difficulty with inspiration. What are the restrictive diseases? Interstitial restrictive disease, lung disease, fibrosis, any scarring of the tissue. Scar tissue. Fibrosis means thickening of the lung tissue, scarring of the lung tissue, sarcoidosis, silicosis, asbestosis, or simply obesity. The excessive fat, it can restrict. So fat itself is a restriction, obesity, or even myasthenia gravis, where you can have autoantibodies against the nicotinic receptors. So that can also cause a restriction. Diaphragm muscle, if it is affected, restrictive disease. So all these are examples for restrictive lung diseases. So we'll go back to that Tiffany index. Based on Tiffany index, how will you differentiate obstructive disease and restrictive disease? In obstructive disease, you're having more problem with expiration. You're not able to send out enough air outside. So out of the tool, in both the cases, FVC has decreased to 2. But in obstructive lung disease, out of the 2 liter, you will be able to push out only 1 liter in the first second. So if you take 1 by 2, ratio of 1 by 2, FEV1 by FVC, 1 by 2 is 50%. See, Tiffany index from 83, it has fallen to 50%. If Tiffany index decreases to 50%, then you can make a gross diagnosis obstructive lung disease. What happens in restrictive lung disease? FVC is only 2 liters. Out of the 2 liter, in the first second, 1.8 liter has come out. Because what is the underlying problem in restrictive disease? You have restriction. So there's more problem with inspiration. So when you have more difficulty with inspiration, expiration is not affected. So that's why out of the 2 liter, 1.8 liter is coming out in the first second itself. There's no problem with expiration. Inspiration only is more affected. So that is why if you take this ratio now, FEV1 by FVC, 1.8 by 2, this will give you 90%. If Tiffany index increases to 90%, then it could be restrictive lung disease. So you cannot interpret this as more than normal. 83 is normal, 50 is less than normal, so it is 90. So is it more than normal? You cannot predict like that because FVC is not 4 liter. Normal FVC is 4 liter, but here FVC itself is 2 liter. It is 1.8 out of 2 liter. It's not 1.8 out of 4 liter. It's 1.8 out of 2 liters. FVC itself has decreased. So that's why it looks like as though the ratio is more than normal. So it's not like that. In restrictive disease, value can go up to 90%. So this is the difference between restrictive and obstructive disease. So the other curve which can help you in doing this differentiating restrictive and obstructive disease, this is called the flow volume loop of the lungs. You'll ask the patient, to do a forced breathing into the machine, a deep inspiration followed by deep expiration. So when the person is doing deep inspiration followed by deep expiration, the curve goes like this. So below one is called as the inspiratory curve, and the one that is above is the expiratory curve. You have volume in liters on x-axis and flow in liters per second on y-axis. How will we analyze this curve? So we'll see what is normal curve, what happens in restrictive and obstructive disease. In normal curve, the black one is the normal curve. The normal curve, the black one, so I just mark the residual volume and the total lung capacity. The residual volume is this part of the curve, which is not at all coming into the loop. It is out of the loop. So that part of the curve, which is not at all coming into the loop, it means that air is, you're not breathing that air out. Which air you will not, which volume of air you will not breathe out, it will stay back as a residue. That's called residual volume. So this part of the curve, which is not coming into the loop. So it's not into the breathing process, it's staying as a residue in the lung. So that is called the residual volume. And this part of the curve, where you add up the residual volume plus that part which is into the loop, both if you add up, that is the total lung capacity. This is the residual volume and totally it's the total lung capacity. That's the normal interpretation. This curve can be shifted to the right side like this blue curve or like the green curve. So the blue one denotes restrictive disease. And the green one denotes obstructive disease. So what happens in restriction? In restrictive disease, there's some restriction. You're not able to, restrictive disease is a problem with inspiration. There's some restriction, you're not able to inspire properly. So when you're not able to inspire properly, what will happen to the residual volume? The inspiration itself is less. Air that goes into the residual volume also will be less. So residual volume has decreased. See, this is residual volume. In the blue curve, that part which is not coming into the loop, the residual volume. Look at the residual volume, it's less. So what happens to the total lung capacity? This is total lung capacity. Residual volume is a part of total lung capacity. So if residual volume is decreasing, total lung capacity also will decrease. So decreased residual volume, decreased total lung capacity in restrictive disease. In obstructive disease, there is more difficulty with sending out the air. Expiration is difficult. If you have difficulty in moving out the air, more air stays inside as a residue itself. So residual volume, so what has happened to the residual volume? The green curve has increased. More air is staying inside itself as residue. So residual volume increases. If residual volume increases, what will happen to the total lung capacity? That also will increase. Total lung capacity also increases. So in obstructive disease, residual volume increases, total lung capacity increases. This is called the flow volume loop. So you should be able to mark the flow with the volume. Back to the question. A 54-year-old asthma patient. Asthma is an obstructive disease. So they're asking you the change in obstructive disease. Which of the following is expected to be increased in this patient? Total lung capacity increases? Yes. Residual volume increases? Yes. What happens to Tiffany index in obstructive disease? Tiffany index falls to 50%. Normal is 83%. So Tiffany index decreases. Only TLC and RV will increase. Tiffany index will decrease. That's why the answer is option D. Only A and B. Yes, sarcoidosis is also Dr. Moore. There's deposition of this foreign body in the lungs. Sarcoidosis, asbestosis, silicosis, any deposition of these foreign bodies in the lung. So that can increase your, yes, that is also restrictive disease only. The eighth question. The question is about respiratory quotient. In a 70 kg man, oxygen consumed 50 ml per minute and carbon dioxide exhaled 200 ml per minute. Calculate the respiratory quotient in this patient. What is respiratory quotient? RQ ratio. That is called the respiratory quotient. The formula for respiratory quotient is CO2 exhaled by oxygen consumed. This is the RQ ratio, the formula. Let's note down this formula. CO2 exhaled 200 ml per minute. Actually, these are all the normal values. Normal CO2 exhaled is 200 ml per minute. Oxygen consumed 250 ml per minute. So if you substitute all this, you will get 0.8. 0.8 is the normal RQ ratio. All these are actually normal values. The normal RQ ratio, respiratory quotient, is 0.8. The ninth question. A patient with chronic pain undergoes transcutaneous electrical nerve stimulation for pain relief. What is the physiological basis for this? Transcutaneous electrical nerve stimulation, that is called the TENS. The reason behind, physiological mechanism behind TENS is gate control theory, gating at the level of spinal cord. So we'll learn gate control theory and we'll come back to this. What are the endogenous pain inhibiting systems? See, your body can give you pain or it can even inhibit your pain. That is called endogenous pain inhibiting system. There are three endogenous pain inhibiting systems by which your body can decrease your pain. Mesencephalic pain inhibiting system, endogenous opioid system, and gate control theory. What is mesencephalic pain inhibiting system? So this one, mesencephalic mean related to the midbrain. So this one starts in the midbrain, comes down through pons and medulla to the spinal cord. This is called the mesencephalic pain inhibiting system. So this mesencephalic pain inhibiting system, this would activate the inhibitory interneurons. So the negative structures you see here are inhibitory interneurons. These mesencephalic pain inhibiting system, it activates the inhibitory interneuron to the pain pathway. This red one that you see is the pain pathway. They are activating the inhibitory interneuron to the pain pathway. So if the inhibitory interneuron is activated, this will go and inhibit the pain pathway. That's how your pain comes down. So that is the mesencephalic pain inhibiting system. There's the first system which is bringing down your pain. The example for mesencephalic pain inhibiting system, acupuncture. One technique that they use small needles and they keep pricking on the spinal cord. So when they prick on the skin, they know which area to prick to activate this mesencephalic pain inhibiting system. They'll keep pricking on this mesencephalic pain inhibiting system to activate this system. When this is activated, your pain will come down. That forms the basis of acupuncture. The other clinical applications of mesencephalic pain inhibiting system, stress-induced analgesia. In stress-induced analgesia, stress releases noradrenaline, and noradrenaline is a part of this mesencephalic pain inhibiting system. Therefore, it blocks the pain. That's why when you are in intense mental stress, you will not feel your physical pain. It's called stress-induced analgesia. This is the first system. The other system, endogenous opioid system. What are the endogenous opioids? Endorphin, enkephalin, and dynorphins. These are the endogenous opioids. Endogenous opioids, they are a part of this pain inhibiting system. They can inhibit the pain, they can block the pain pathways, endogenous opioids. The drug form of these opioids, endogenous, are produced inside the body. What are the drug forms of these opioids? Morphine, fentanyl, codeine. All these are drug forms of these opioids. That's why you use these drugs to bring down the pain. Mostly in post-operative also you'll see all these drugs. To bring down the pain, you can use these opioids because opioids will bring down the pain. The other system, gate control theory. See, there is opening and closing of the pain gates in the spinal cord. So that only is helping to bring down the pain. So what is that opening and closing of these gates? When you have pain, pain is carried by these pain fibers. When pain fibers go to the spinal cord, they would open the pain gate. That's why you feel the pain. They open the pain gate. What are the fibers which will close the pain gate? Touch and pressure fibers, the A beta touch and pressure fibers, when they go into the spinal cord, they would close the pain gate. So if you stimulate the touch and pressure fibers, pain gate is closed. So if pain gate is closed, it's helping you to bring down the pain. So that's how gating at the level of spinal cord helps to bring down the pain. Pain fibers will open the pain gate, touch and pressure fibers will close the pain gate. This is called gate control theory. One mechanism by which you can activate gate control theory, TENS, transcutaneous electric nerve stimulation. You're using electrodes to stimulate these fibers. Then you use electrodes and selectively stimulate the A beta. So it will close the pain gate, thereby your pain will come down. So TENS is based on gate control theory. Go back to the question. A patient with chronic pain undergoes transcutaneous electric nerve stimulation. What is the physiological basis? TENS is based on gate control theory, gating. Answer is A, gating at the spinal cord. Transcutaneous electric nerve stimulation. It's a pain therapy. In plain clinics, you can see it's a technique where you use electrodes and selectively you activate the A beta fibers. A beta fibers are touch and pressure fibers which will close the pain gate. So selectively, if you are able to activate the A beta fibers, it will close the pain gate, thereby pain will come down. So it's called TENS, transcutaneous electric nerve stimulation. It's a treatment of pain therapy. Tenth question. In one of the Viva exams, the examiner asks the question, who discovered ECG? The student is not able to recall the answer. So it's not ECG, it's actually EEG. Who discovered EEG? Electroencephalogram. The examiner is giving a clue. The name rhymes with something that you eat at McDonald's. See, what is that McDonald's? They are trying to correlate. You eat burger. Yes, good, Dr. Karthik. Rhyming. See, he's trying to get that name, Hank's Burger. The name is, the person who discovered EEG is Hank's Burger. To get that name burger, examiner is giving a clue. McDonald. You eat at McDonald's, something related to burger. So you get that name burger. Now the student is able to recall the right answer. What is the physiological basis of this type of memory? See, this type of memory is called priming. Priming means by giving clues, or when you combine something which you don't know with something which you already know. I mean, you know burger, but you don't know the name of the scientist as burger. So you try to correlate something which you don't know with something which you already know by giving clues. That is called priming. This is one method of learning, priming. The answer is priming. What are the other options? Classical conditioning. So classical conditioning means the Pavlov's experiment, the dog and the bell experiment, where you ring the bell and you give food to the dog. The dog is learning that when you ring the bell, you will give him food. That's called classical conditioning. Operant conditioning is by activating reward centers and punishment centers in the brain. Working memory. It's a very temporary form of memory by which you remember some things for a very short period, very temporary form of memory, working memory. So this answer is priming. By giving clues, you can learn things. That's what we do know when we set this mnemonics and all. They don't know something, you try to learn that by correlating with a movie or a song or somebody else you like. So that's called priming. Answer is priming. B. Priming. 11th question. Rate of synthesis of various forms of hemoglobin is shown. Gamma chains is indicated by which of the following curve? So you can see A, B, C, and D. There are four curves here. Gamma chain correlates with which of the curve? So what is gamma chain? Fetal hemoglobin has alpha chain and gamma chain. Adult hemoglobin has alpha chains and beta chains. So fetal hemoglobin, alpha and gamma. So during the period of gestation, that is the fetus. See which one is increasing. You can see that B is increased during the fetal period, and when it changes to adult hemoglobin, gamma will become beta. So after birth, it should come down. So this B curve, in the fetus it is increasing, and after birth it is decreasing. So that is gamma chain. The answer is curve B. Curve B is the gamma chain. The answer is option B. The 12th question. Can we have a small break and then we'll continue with this? Yes? Yes, we'll have a small break, maybe 5 to 10 minutes. Take a small break and we'll continue the 12th question. Yes, can we start? So we have asked at what time till the class is. Class is till 9. The 12th question. A 51-year-old female patient was admitted in the emergency department with blurred vision, headache, dizziness, and vomiting with 1 day of evolution. On examination, flaccid paralysis of the voluntary muscles. Concomitantly, the patient's husband also reported self-limited diarrhea and vomiting. A history of homemade sausage, broad beans, and honey consumption was registered. What would be the most likely mechanism of action of the toxin detected here? So, what is the toxin detected here, first of all? Clostridium. Good, Dr. Karthik, it's Clostridium. Clostridium botulinum toxin, very common in homemade sausages, broad beans, and honey consumption. All this is related to Clostridium botulinum. See, Clostridium botulinum, the mechanism of action of Clostridium botulinum is they are all blockers of snare proteins. What are snare proteins? See, for the vesicles to release acetylcholine, the vesicles to release acetylcholine, you need snare proteins. So the role of snare proteins is to release acetylcholine. If Clostridium botulinum blocks the snare proteins, then release of acetylcholine is blocked. Acetylcholine is a neurotransmitter of the neuromuscular junction. This is going to cause contraction. If acetylcholine is blocked, this results in decreased contractions, decreased muscle contractions. That is called flaccid type of paralysis. Flaccid paralysis. If you have increased contractions, that is called spastic paralysis. Spastic paralysis occurs in Clostridium tetani. This is Clostridium botulinum, which causes flaccid paralysis. Muscles will lose their tone, decreased contraction. Because acetylcholine is blocked, why acetylcholine is blocked? Snare proteins are blocked. Snare proteins are important for acetylcholine release. If you block snare proteins, acetylcholine release is blocked. Therefore, decreased contraction and flaccid paralysis. So the answer is blocker of snare proteins. And this is typically seen in food poisoning cases. This answer is C, blocker of snare proteins. Which of the following event succeeds the first heart sound in cardiac cycle? The question is about cardiac cycle. First we'll learn cardiac cycle, then we'll come back to this. What are the phases in the cardiac cycle? In the cardiac cycle diagram, this is called the Vigor's diagram of cardiac cycle. You have pressure curves and volume curves. How will you interpret the cardiac cycle diagram? In the pressure curves, look at the pressure curves. There are 3 pressure curves. So the top one is called aortic pressure curve. The red big curve is called ventricular pressure curve. The small creeping curve, that is called atrial pressure curve. There are 3 pressure curves: aortic pressure curve, ventricular pressure curve, and atrial pressure curves. So how will you interpret these curves? Look at aortic pressure curve. Look at the pressure values. What is aortic pressure? The pressure in the aorta. The systemic blood pressure, 120/80. See, we record it in the brachial artery, but that is not the pressure originating in the brachial artery. That's the pressure originating in the aorta. So aortic pressure curve denotes the systemic pressure, 120/80. Look at the values corresponding to aortic pressure curve, 120 and 80. So 120/80 is the aortic pressure curve, because aortic pressure is systemic pressure. Systemic pressure is 120/80. So the curve which has 120/80 is aortic pressure curve. Ventricular pressure curve. The biggest curve is ventricular pressure curve. Yes, obviously it's biggest because the ventricular pressure, left ventricle. The ventricle is a thick muscle mass, bigger chamber. So definitely it will produce huge differences in pressure. So the biggest curve should belong to the ventricle. So the red curve is the ventricular pressure curve. Atrial pressure curve. The atrial pressure curve, atrium is a small chamber. So inside the atrium, the changes, the pressure changes and the volume changes are not very significant. That's why the smallest curve, just try to correlate the pressure changes on the y-axis. So this is even less than 20 millimeters of mercury. Such small differences in pressure can be produced by a small chamber. The small chamber is the atrium. That is called the atrial pressure curve. There are three pressure curves: aortic pressure curve, ventricular pressure curve, and atrial pressure curve. In volume, look at the volume curves. You have only one volume curve, the blue colored curve. We are more concerned about the ventricular pressure changes. Sorry, the ventricular volume changes. See, because atrium is a small chamber, so not much of volume and pressure change can happen in the atrium. But ventricle, thicker muscle mass, bigger chamber, so you can have significant volume changes in the ventricular curve. So this blue one denotes ventricular volume. Ventricular volume. Or there's only one volume curve, it should belong to the ventricle. This is how you will read the cardiac cycle diagram. What are the phases of the cardiac cycle diagram? The initial phase, atrial systole, followed by atrial diastole. Atrial diastole is not significant, so you don't see that. Followed by ventricular systole, followed by ventricular diastole. So atrial systole, atrial diastole is not there. Ventricular systole, ventricular diastole. So these are the phases of the cardiac cycle. In between, there are some phases. So look at the valvular events into this. At the end of atrial systole, so when atrium is contracting to push the blood into the ventricles, after it has pushed the blood into the ventricles, this valve will close. What is that valve? Between the atrium and the ventricles? AV valve. So at the end of atrial systole, see, AV valve closes. AV valve closes. Now, which valve will open? You have the aorta. This is the aortic valve. Now, aortic valve will open. Blood flows into the aorta. So, next event, aortic valve opens. When aortic valve opens, blood flows into the aorta. Then the aortic valve will close, followed by aortic valve closure. Again, AV valve will open. AV valve opens. So followed by AV valve opening. This is how you will fit the valvular events into this. So in between, there are small periods where both valves are closed. So at the end of atrial systole, AV valve closes and aortic valve should open. So AV valve has closed, aortic valve is going to open. There's a small period just before the opening of this aortic valve. AV valve is closed, aortic valve is just going to open. There's a small period where both the valves are closed. So during this period where both the valves are closed, the volume inside the ventricle cannot change because there's no opening, both the valves are closed. So volume remains same. So during this period, I'll mark it in yellow. So during this period, between AV valve closure and aortic valve opening, when both the valves are closed, that small phase where both the valves are closed, so this is called isovolumetric contraction phase, because the volume inside the ventricles is not changing. So it's called isovolumetric contraction phase. That is followed by opening of aortic valve, ejection, aortic valve closes, AV valve opens. See, aortic valve has closed, AV valve is going to open. Again, you'll have a small period, but aortic valve is closed, AV valve is just going to open. That's also closed. A small period where both the valves are closed. So when both the valves are closed, again the volume cannot change. That is again a isovolumetric phase. We mark that in pink. So this phase between aortic closure and AV valve opening, isovolumetric phase, it's followed by diastole. So isovolumetric relaxation phase. There are two isovolumetric phases. Isovolumetric means both the valves are closed, so the volume is not changing. That is called isovolumetric phase. Isovolumetric contraction, isovolumetric relaxation. So now look into the question. Which of the following event succeeds the first heart sound in cardiac cycle? So what is first heart sound? What are the heart sounds due to? Closure of the valve produces the heart sounds. AV valve closure produces S1. Aortic valve closure produces S2. Two heart sounds. So they're asking you, what is that event following S1, AV valve closure? What is this event? After AV valve closure, you have this small phase, isovolumetric contraction phase. When AV valve closes, aortic valve is going to open. In between, before aortic valve could open, there's a small phase called isovolumetric contraction phase. So which of the following events succeeds the first heart sound? Isovolumetric contraction phase. A. We'll see how many of you have got this right. Yes, the asthma question, equally right and wrong. Yes, RQ ratio, all of you have got it right, 0.8. Chronic pain, TENS, transcutaneous electrical nerve stimulation, is gating. Most of you have done it right, gate control theory. Viva exam, priming, that also most of you are right, priming. Hemoglobin, most of you have gone wrong for option D, so it's B. A 51-year-old female, emergency, blurred vision, headache, dizziness, snare protein, good. Most of you have got it right. See, what are the snare proteins? We discussed about these snare proteins. What are the snare proteins? Synaptotagmin, synaptobrevin, syntaxin, SNAP25. The four snare proteins: synaptotagmin, synaptobrevin, syntaxin, and SNAP25. These are the snare proteins. Which of the following event succeeds the first heart sound in cardiac cycle? Yes, most of you are right. Isovolumetric contraction. Next question. A twofold decrease in extracellular potassium level causes which of the following change? Okay, most of you have gone wrong. Some of you are right. We'll do this. A twofold decrease in extracellular potassium level causes which of the following change? First, let's learn the action potential, and only then you'll be able to do that. This is the action potential curve, where you have depolarization due to sodium influx and repolarization due to potassium efflux. hyperpolarization, this small phase where it goes beyond repolarization, that is called hyperpolarization. The reason for hyperpolarization is slow, leaky potassium channels. Slow, leaky potassium channels. So these are the phases of action potential curve and the ionic events. So the question is about a two-fold decrease in extracellular potassium level causes which of the following change? So if potassium level is decreasing, extracellular potassium is decreasing. Repolarization, the reason for repolarization is potassium is moving out. Potassium efflux, that's the reason for repolarization. If extracellular potassium is decreasing, it means the gradient is even more. Extracellular potassium is very less. Now, the gradient is easily favoring the movement of potassium out of the cell. If extracellular potassium is increasing, then the gradient will be destroyed because the normal gradient for potassium is more inside the cells and less outside the cells. This is the normal gradient for potassium. If you have more potassium outside, it's in the reverse. Gradient is destroyed. But if you have less potassium outside, this is going to further increase the pressure, the concentration gradient, and therefore easily potassium can move out. So when you have a decreased potassium levels, easily potassium moves out. When easily potassium moves out, that causes hyperpolarization. If you go for repolarization, still potassium is low in the extracellular fluid. So still you have the gradient. Now potassium will keep on moving outside. So repolarization, it will go for hyperpolarization. Even it's going beyond RMP, hyperpolarization, because still the gradient is favoring. So it goes for hyperpolarization. Look at the curves that are given. You have time and membrane potential. So D, the black D curve, this is like the normal one. So the baseline, RMP. Which curve is going beyond the RMP? Hyperpolarization, E. So this only is going beyond RMP. So that denotes hyperpolarization. The answer is option D. So when you have questions like this, no, A, B, C, D is there in the diagram also. Options also A, B, C, D is there. So you should be very careful when you attend these type of questions. The answer is option D. Answer E. Hyperpolarization. It's going beyond the RMP. Identify the cell type shown in the image. Other curves. See, other curves are like they are going above the resting membrane potentials. So that could not be the answer for this. If it's going for hyperkalemia, then you can have that. In hypokalemia, it will go beyond the RMP. So it's going for hyperpolarization. Identify the cell type shown in the image. This is a repeat question. A histology image was given. And look at the cell. You can see a neuron here. It's very clear that it's a neuron. Can you see the diffuse arrangement of dendrites? One dendrite is giving rise to many dendritic process. They are having diffuse arrangement of dendrites. So such diffuse arrangement of dendrites, very typical of Purkinje cells of cerebellum. Purkinje cells of cerebellum. The answer is A. Purkinje cell of cerebellum. See, Purkinje cells of cerebellum, they are example for multipolar cells. But typically, the arrangement is one dendrite will give connection, will divide into many small dendritic processes. This diffuse connectivity is very characteristic of Purkinje cell. So it's a Purkinje cell. What are the different types of neurons? Unipolar neuron. Unipolar means from the cell body, a neuron has a cell body, an axon, and dendrites. From the cell body, if there is only one process coming out. That is called unipolar. From the cell body, there's one process. Uni means single. One process coming out, that is the axon. Example for unipolar, invertebrate neurons. Insects. Invertebrates can have unipolar. Bipolar. Bi means two. From the cell body, if there are two processes coming out, then it is called bipolar cell of retina. Example, in the retina, you have bipolar cells. See, from the cell body, one process is axon, the other process is dendrites. From the cell body, if one process is axon, the other process is dendrites, two processes are coming out. Typical example, bipolar cells of the retina. Pseudo-unipolar. Pseudo means false appearance. So this will give you a false appearance as if it is unipolar. The cell body from which one process comes out, it looks like unipolar, but ultimately this one process will again divide into two processes. It forms a central axon and a peripheral axon. Actually, there are two processes, but it looks like as though there is only one process. So this is called pseudo-unipolar type, typically seen in ganglion cell. Difference between 1 and 2. Which 1 and 2, doctor? Okay, I'll repeat that. Unipolar means from the cell body, there's only one process. What is that one process? Axon. Unipolar type. Bipolar means from the cell body, two processes. One process is called axon, other process is dendrite, and the dendrite will again divide into many small dendrites. So that is bipolar cell. Example, in eyes, retina, you can see bipolar cells of the retina. Pseudo-unipolar cell. Pseudo means false appearance. This will look like as though there is one process, but ultimately it will divide into two processes, a central axon and a peripheral axon. So in bipolar cells also you have two processes, but one is axon, one is dendrite. But in pseudo-unipolar, here also there are two processes. Both the processes are axons. Peripheral axon, central axon. Both the processes are axons. This is pseudo-unipolar type. Multipolar cells. Multi means many. From the cell body, if you have many processes coming out, one longest process is axon, you have other processes coming out, the dendrites. This is called multipolar type. From the cell body, multiple processes are coming out. The longest process is the axon, others are on the dendrites. Example, motor neurons of the spinal cord. This is the most common type also. Motor neurons responsible for muscle movements, they are of multipolar type. Other variants of multipolar type, pyramidal cells of hippocampus, they also have multiple processes. Purkinje cell of cerebellum, this is what we are saying now. From the cell body, one axon and multiple dendrites. Dendrites again divide into diffuse dendritic connections. So this type of diffuse dendritic connection is typical of Purkinje cell of cerebellum. That's what we are learning. That's what is the question. The answer is A, Purkinje cell of cerebellum. 16th question. A 24-year-old female presented with a 6-day history of progressive weakness in her lower limbs, unable to walk, complete paralysis. On investigation, diagnosed to have autoimmune disorder of peripheral neurons. Which of the following mutations would you suspect? See, autoimmune disorder of peripheral sensory neurons. So this is actually an autoimmune demyelination disorder. So what are the demyelination disorders? What is the clinical importance of learning myelin? In central nervous system, myelination is done by oligodendrocytes. In peripheral nervous system, myelination is done by Schwann cells. In central nervous system, oligodendrocytes, they require myelin basic protein for formation of myelin. Squam cells, they require protein 0 and PMP22. Peripheral myelinating protein 22. So oligodendrocytes require myelin basic protein and squam cells require protein 0 and PMP22. Autoimmune destruction, autoantibodies against myelin basic protein, that is called multiple sclerosis. Autoantibodies against PMP22 and protein 0. Yes, you know what is that disease? Is Varsha, that's clear, or difference between 1 and 2? Okay, now can you answer this? Do you know the name of that disease? Autoimmune disease? Good, Dr. Karthik. GBS, Guillain-Barré syndrome. Guillain-Barré syndrome. So you'll see that multiple sclerosis is a central demyelinating disease because the problem in CNS myelination. But Guillain-Barré syndrome is a peripheral demyelinating disease. Autoantibodies of PMP22 or protein 0. See, sometimes you can even have mutations of protein 0 and PMP22. So that is called Charcot-Marie-Tooth disease. Mutations. This is also a peripheral demyelinating disease. Charcot-Marie-Tooth disease. Mutations of protein 0 or PMP22. Charcot-Marie-Tooth disease. So autoimmune disorder of peripheral sensory neurons. Peripheral means in PNS. Myelination in PNS is because of squam cells with the help of PMP22 and protein 0. So this is PMP22. So if it was a disorder of the central nervous system, then you can think of multiple sclerosis and myelin basic protein. Since this is peripheral nervous system, we'll go with PMP22. We'll see how many of you have given this. Identify the cell type. Yes, most of you have given the right answer. Purkinje cell. Female patient with progressive weakness. See, most of you have given myelin basic protein. So that is the difference. In central nervous system, central demyelinating disease is multiple sclerosis. But this is Guillain-Barré syndrome or Charcot-Marie-Tooth disease where you have peripheral demyelinating disease. Yes, only few of you have given this right answer. Next question. Orthopedician examines a 33-year-old male patient with right forearm injury. The doctor taps over the right forearm from distal to proximal. What is he seeing? Is most of you are right? Nerve regeneration. What is this question on? 17th question. What is that doctor doing? What is the orthopedician doing? Tapping over the right forearm from distal to proximal. So when you tap over the forearm from distal to proximal, see what is he trying to do? What is this called? Tinel's sign or Tinel's test. Tinel's test or Tinel's sign. Whenever there is a nerve injury, you tap from distal to proximal like this. Once you reach the point of regeneration, okay, this is a nerve injury. The nerve has been injured here. So that part of the nerve, which is near to the cell body, that's called the proximal segment. This is the proximal segment. Since this is close to the cell body would give all proteins, enzymes and all. Therefore, this part will go for recovery or regeneration. That's called the proximal regeneration. The proximal segment goes for regeneration. The distal segment. Distal segment is the one which is away from the cell body. There is no cell body. So there's nobody to give proteins, enzymes, and all. So the distal segment will go for degeneration. This was discovered by Waller and it's called Valerian Degeneration. Valerian Degeneration. If this is the site of nerve injury, what this organization is trying to do is tapping from distal to proximal like this. Once he reaches this point, which is the site of regeneration, patient will complain of tingling sensation. So it means that is the point where regeneration is starting. So if you keep tapping from distal to proximal, when you reach that point of regeneration, patient complains of tingling sensation. That is called Tinel's sign or Tinel's test. So Tinel's test is used to identify the site of nerve regeneration. Eighteenth question. A 20-year-old boy, after a motorbike accident, nerve crush injury on his left forearm. How do you grade this type of nerve injury? What are nerve crush injuries? We study the grades of injury and we'll come to this. A person called Seddon, he only classified the nerve injuries. That's called the Seddon's classification of nerve injury. According to Seddon's classification of nerve injury, the top one that you see is a normal neuron, there's no injury. Neuropraxia. Neuropraxia means anatomically nothing has been cut. The nerve has been compressed. So that is neuropraxia. Compression injuries. Compression injury. There is no cut. Nothing has been cut. Anatomically it's normal, but conduction is disrupted. That is called neuropraxia. Compression injuries. Examples for compression injuries: a wrist drop, that's called the Saturday night palsy, where the radial nerve is compressed. So compression injuries are neuropraxia. Axonotmesis, the next form of injury. Axonotmesis. Otmesis means cut. Axonotmesis means the axon is cut. Axonotmesis. Axon along with the myelin sheath is cut. This is called axonotmesis. See, the black line is the center. You have the black line, that is the axon. The axon has been cut. Axon along with the myelin. So this is called axonotmesis. Axonotmesis. Example for axonotmesis: nerve crush injuries. Nerve crush injury, where the nerve has been crushed. Only the axon and the myelin has been injured. The next form of injury, this is the worst form of injury: neurotmesis. Otmesis means cut. Neurotmesis means the whole nerve has been cut. It's called neurotmesis. The nerve has been cut. See, transection injuries. The nerve has been cut. Example, transection injuries. Completely it is cut. That is called neurotmesis. In neurotmesis, there are three types. It depends on which layers are cut. Only endoneurium is cut, the inner layer, or endoneurium plus perineurium is cut, or endo plus peri plus epineurium. All three layers are cut. It depends on which layer is damaged. Only endoneurium is cut, or endo plus perineurium is cut, or all three layers are cut. This is called neurotmesis. The worst form of injury, transection injuries. Nerve has been cut. Very difficult to recover. This is Seddon's classification. There's another classification called Sunderland's classification. So according to Sunderland's classification, there are many degrees of nerve injury. Neuropraxia, first degree injury. Axonotmesis, second degree injury. And in neurotmesis, endoneurium alone is cut, third degree. Endoneurium plus perineurium is cut, fourth degree. All three layers are cut, fifth degree. So based on which layers are damaged, there are 5 degrees of Sunderland's classification. So Sunderland's classification, first degree, the mildest form of injury. Fifth degree, worst form of injury. So nerve crush is the question. It comes under axonotmesis. The answer is axonotmesis. A physician, on examining a diabetic patient for vibratory sense, places a tuning fork over several points on the body. Which of the following sensory receptor would sense vibratory sense? So they have given you the hertz also. 512 hertz. 512 hertz means a high frequency. So vibratory sense is sensed by, yes, Dr. Karthik says Merkel. Any other options? There is Dr. Varsha and Dr. Mohit. Yes, Srinivasa Balaji. Good. D is the right answer. Yes, Dr. Srinivasa is right. The answer is Pacinian. So the question is about vibratory sense. See, what are the tactile receptors? Yes, Priyanka Palnivelan. Nice name. It's also correct. Pacinian. We'll learn about tactile receptors and we'll go back to the question. Tactile receptors. What are the tactile receptors? Meissner, Merkel, Ruffini, and Pacinian. So these are the tactile receptors. And what do they sense? Meissner senses fine touch, Merkel crude touch, Ruffini rotation of joints, and sustained pressure. Sustained pressure. Pacinian, deep pressure and vibration. There's one question on this hertz. Vibrations of 30 to 800 hertz. High frequency vibrations that is sensed by Pacinian. Meissner also can sense vibrations, but very small vibrations, less than 30 hertz. That is sensed by Meissner. So the question is vibratory sense, and if they have given the hertz also. Hypal is a high frequency hertz. So 80 to 500 hertz is Pacinian. So the answer is Pacinian. Meissner also could be, but Meissner is less than 30 hertz. 20th question. In preparation to excise a mole from the patient's back, physician injects lidocaine into the surrounding tissue to anesthetize the area and thus preventing the transmission of impulse down the axon. Which segment of the action potential is blocked by this drug lidocaine? The answer is depolarization, rapid depolarization. Yes, good, Dr. Karthik. Rapid depolarization. 512 hertz, Dr. Asha, 512 hertz was given. 512 hertz is more than 30, so it's Pacinian. So the question is lidocaine, local anesthetics. What is the mechanism of action of local anesthetics? They are all blockers of, this is depolarization due to sodium influx, voltage gated sodium channels. Mechanism of action of local anesthetics. They are blockers of voltage gated sodium channel. So they would block sodium influx, thereby blocking depolarization. They are blockers of depolarization. When you block sodium influx, you can stop the conduction of impulse. So if there's pain which is being conducted, if you give local anesthetics, it will block depolarization, block the sodium channels, thereby it will stop the pain from being conducted. That's how local anesthetics, they bring down the pain, they stop the transmission. So mechanism of action is blockers of depolarization or rapid depolarization. False statement regarding cerebellum. Flocculonodular lobe, vestibulocular reflex, spinocerebellum planning, lateral hemispheres coordination. D is both B and C. 5 to 12. It is not 5 to 12, doctor. Was it 5 to 12? It's a 512 tuning fork. 512 hertz. It's not 5 to 12, a 512 hertz tuning fork. Okay. If it is less than 30, as you're saying 5 hertz or 12 hertz, then it can be Meissner, correct. But here it is 512. So it is more than 30, that is Pacinian. As we learn about cerebellum, and we'll come to this. So cerebellum, it has lateral hemispheres, parts of the cerebellum. Lateral hemispheres. Lateral hemispheres are called cerebrocerebellum. The role of cerebrocerebellum, they help in planning. The medial part, it's called the spinocerebellum. So why is it called spinocerebellum? It connects to the spinal cord and from there to all parts of the body, and it will check for coordination. Spinocerebellum only checks for coordination. The center part of spinocerebellum is called vermis. The other parts, vestibulocerebellum. Vestibulocerebellum is made up of nodulus and flocculus. That's why it's called flocculonodular lobe. Flocculus and nodulus. It's called the flocculonodular lobe. Vestibulocerebellum. The role of vestibulocerebellum is related to balance. See, anything starting with vestibular apparatus, vestibulonucleus. Vestibular means balance. So this helps in balance, equilibrium, gait, proper walking, gait. Flocculus and nodulus are related to eyeball movements. That is called vestibulo-ocular reflex. Vestibulo-ocular reflex. So nodulus and flocculus are related to eyeball movements. That is related to vestibulo-ocular reflex. See, other name for vestibulo-ocular reflex is doll's eye movement. Doll's eye movement is, have you seen the head movement and eyeball movement of Barbie doll? You try to rotate the head to one side, immediately the eyeball will turn to the other side. So if you have seen these movies like Annabelle and all, where the toy is a ghost, so when they keep close-up shots, they'll slowly turn the head to one side. When head turns to one side, eyeball will rotate to the opposite side. That is called doll's eye movement. Head turns to one side, eyeball rotates to the opposite side. Doll's eye movement. So these are the parts of the cerebellum. What are the nuclei in the cerebellum? So nuclei inside the cerebellum. So the mnemonic for this is doctors eat good food. So what are the nucleus? From lateral to medial or you can say from outer to inner. The arrangement is doctors eat good food. D, E, F, G. D is the lateral most and F is the medial most. So dentate, emboliform, globose, and fastigial. So these are the nuclei D, E, G, F, and dentate is the lateral most. Fastigial is the medial most. So mnemonic is doctors eat good food. Now look at the statements. Flocculonodular lobe, vestibulo-ocular reflex. Yes. Spinocerebellum, planning. Spinocerebellum is for coordination. Lateral hemispheres are called cerebrocerebellum. Cerebrocerebellum is for planning. See, both are interchanged. So false is both B and C. Both B and C are false. Following a thoracotomy and removal of small lung nodule, one of your patients is complaining of severe pain at the incision site and underlying chest wall. The standard doses of pain medication does not seem to have the desired result, and you are afraid to give too much for the fear of oversedating the patient. Adequately control this patient's pain. You decide to start him on morphine. The question is about morphine. Patient controlled analgesia pump. This works very well, and by the following morning, he has no pain. Through what mechanism does morphine decrease the pain? So mechanism of action of morphine. Do you remember morphine? We learned in opioid system is endogenous opioid system. These endogenous opioids, endorphin, enkephalin, or dynorphin, or the drugs that you give here, they act at the level of spinal cord. They will block the pain transmission at the level of spinal cord. So modulating the spinal cord response to painful stimuli. See, because these endorphins are produced by that inhibitory interneuron in the spinal cord. So inhibitory interneurons are at the level of spinal cord only. They only produce these opioid analgesics. So morphine, it acts at the level of spinal cord. Third question. A 58-year-old known case of hemiplegia patient demonstrates a series of involuntary rhythmic muscular contractions and relaxations of the ankle joint. So what are they talking about? So look at me. In upper motor neuron hemiplegia patients, if you dorsiflex, if this is the foot and this is the leg, just imagine this is the foot and this is the leg. If you dorsiflex the foot once like this, multiple times the patient will be doing this. See, this is called clonus. You dorsiflex the foot once, to leave it multiple times, you will do like this. That's called clonus. So clonus is typically seen in hemiplegia, upper motor neuron disease. Clonus. I can show you clonus. Just look at this. Because you have video-based questions also in your exams. Look at clonus. So they will dorsiflex the foot once. I think you can see the video. See? This is called clonus. In upper motor neuron disease, in hemiplegia, not in cerebellum, typically seen in upper motor neuron disease. Corticospinal tract lesion, you will see clonus. Clonus is one of the tests for identification of upper motor neuron disease. That is clonus. Involuntary rhythmic contractions of the foot. The special characteristics of upper motor neuron diseases, clasp knife spasticity and clonus. Both are typical of UMN disease. Lower motor neuron disease, fasciculations. clasp knife and clonus are typical of UMN disease, presenting clinical features. Fasciculation is present in LMN disease. UMN disease is corticospinal tract disease. Corticospinal tract disease, hemiplegia, UMN disease, all are same. See, what is an upper motor neuron disease? What are the upper motor neurons first? From the motor cortex up to the point where it reaches the spinal cord, they are called upper motor neurons. From spinal cord, from the anterior horn cell, you have A alpha and A gamma, which goes to the muscles. So A alpha and A gamma, which goes to the muscles and also anterior horn cells, they are all lower motor neurons. So all this is lower motor neurons. So any damage to upper motor neuron means corticospinal tract is affected, hemiplegia, all are same. If A alpha, A gamma or anterior horn cell is damaged, then that is lower motor neuron disease. In element disease only you will see fasciculations. A 71-year-old male patient presented with a minor motor vehicle collision. Upon initial examination, patient was confused, semi-lethargic, emotionally labile. CT shows bilateral temporal lobes are damaged, especially amygdala is damaged. What could be the most probable diagnosis? Yes, this one, did you answer this one? Let's see how many of you have answered this. This vibration, most of you have answered. Depolarization, lidocaine, most of you have given the right answer. Cerebellum also, most of you are right. Is this? Only one of you have given the right answer. That is about morphine. So they are endogenous opioids. They act at the level of spinal cord. Hemiplegia, clonus, yes, most of you have given this. Kluver-Bucy syndrome, yes, most of you are right. Kluver-Bucy syndrome. What is Kluver-Bucy syndrome? Bilateral damage to amygdala. This is called Kluver-Bucy syndrome. What is the role of amygdala? Amygdala plays role in emotions, especially fear and sex. So when there is damage to amygdala, bilateral damage to amygdala, the patient will not have fear, no fear. Because he has no fear, he will do anything. The children, they'll keep doing anything. They will jump into water, they'll peep from heights because their amygdala is not developed. They don't know what is fear. They don't know what is fear. So that's why they do all this. So that is called hypermetamorphosis. Hypermetamorphosis. A tendency to do anything. That's called hypermetamorphosis. And also sexuality can be affected. It's called hypersexuality. So these are classical features when there is damage to amygdala. That is called Kluver-Bucy syndrome. Bilateral damage to amygdala, Kluver-Bucy syndrome. Repeat question. Answer is C, Kluver-Bucy syndrome. Yes, hypersexuality, hyperphagia, all this C. Kluver-Bucy syndrome. See, we cannot go with other options. What is andrograde amnesia? Damage to hippocampus. Because hippocampus only converts short-term memories into long-term memories. If hippocampus is damaged, you will have andrograde amnesia. Wernicke's encephalopathy. This is seen in damage to mammillary body. So again, mammillary body is also in the hippocampus only. The hypothalamus. In chronic alcoholism or thiamine deficiency, you can have degeneration of mammillary body. That can be related to Wernicke's encephalopathy. Alzheimer's. What is Alzheimer's? Age-related degeneration of nucleus basalis of Maynard, which produces acetylcholine. If this is damaged, age-related memory loss, Alzheimer's, nucleus basalis of Maynard, the basal forebrain, it produces acetylcholine. If that is damaged, Alzheimer's disease. It's the last question. 25. With 25, we'll wind up. A 63-year-old female patient was referred to the cardiac OPD. Increasing symptoms of fatigue, dyspnea, swelling of the lower limb, enlargement of the abdomen. ECG was taken. Look at the ECG. So the features that they are trying to show you in the ECG is, look at the waves. Preceding the QRS, you can see the P waves. Look at the P wave. The P wave has become very tall. See, it's called tall P waves. Tall P wave, too big. Tall P waves. So the clinical finding that they are trying to show you in the ECG is tall P waves. What is the reason for tall P waves? See, tall P waves. So what is the normal P wave? Normally, P wave should be 2.5 small squares in width as well as in height. 2.5 small square. If it goes more than 2.5 small square, that's called wide P. If it's taller than 2.5, tall P. So you can see tall P waves here and wide P waves here. So how will you correlate this? P wave is due to atrial depolarization. P wave is the atrial depolarization wave. So this P wave, when atrium is enlarged, it can become taller or wider because P wave is due to atrial enlargement, atrial depolarization. In right atrial hypertrophy, tall P wave. Left atrial hypertrophy, wide P wave. A wave is due to atrial depolarization. So when atrium is enlarged, right atrial hypertrophy, tall P wave. Left atrial hypertrophy, wide P waves. So this is about the tall P waves and the wide P waves. So in the question, you can see tall P waves. So you can correlate tall P waves with right atrial hypertrophy. Wide P wave is left atrial hypertrophy. This is right atrial hypertrophy. Because of right atrial hypertrophy, see that is giving more pressure on the veins. That's why the patient is developing edema, enlargement of the abdomen, all that is because of raised venous pressure. So the answer is B, right atrial hypertrophy. It's exactly 9 o'clock. So we'll finish with this. So next session, we'll discuss the remaining questions. Yes, hope it was a useful discussion. So any changes you want, any doubts you have, please ask in the chat box. Yes, Dr. Mayank Tiwari, nice name. Right ventricular hypertrophy, not right ventricular hypertrophy. It is right atrial hypertrophy because P wave is due to atrial depolarization. Yes, thank you so much. Good night to all. We'll see you in the next session. Varsha, question number 1. First question. Huh? I think you are late. Huh? First question.